Hello, my name is Henny Beckers from the University Eye Clinic of Maastricht, the Netherlands. In this ESCRS video of the month, Dr Agarwal presents a new minimally invasive approach for a glaucoma surgery called minimally invasive microsclerostomy. In this method, with a device consisting of two parts, a surgical tool, which is a stainless steel cutting blade with a penetrating tip, and a conjunctiva protector sleeve, is used. The surgical component is connected to a device that is controlled with a foot switch to rotate the blade. This blade is inserted through a scleral tunnel into the anterior chamber, and after starting rotating with the foot switch, a scleral 50 to 100 micrometers wide drainage channel is created to produce a filtering bleb. The system has been tested in pigs, and currently human studies are undertaken. Mitomycin C has to be used with the procedure and is injected subconjunctivally 60 minutes before the procedure starts. Dr Agarwal has shown some promising preliminary results after 6 months of follow-up. However, efficacy and safety have to be further looked into. Conjunctival tears and buttonholes may appear during the procedure, as well as hyphemus. Entangling Tenon's capsule and spontaneous outward propulsion of the handpiece can also occur. In one case, iris tissue was caught into the handpiece, leading to complete loss of iris tissue. Thus, especially safety of the procedure seems an issue that has to be improved further down the line.
Dr. Agarwal is a consultant for Sanoculis Limited. None of the others have any financial interest in the contents of the film. MIMS, minimally invasive microsclerostomy, a promising glaucoma technique. Glaucoma is a silent killer. According to the 2010 World Health Organization, it accounts for 2% of visual impairment and 12% of global blindness. Increased intraocular pressure IOP and subsequent retinal ganglion cell death lead to the irreversible loss of visual field. Control of IOP, the only modifiable risk factor early in the disease process, has been shown to delay or even arrest glaucoma progression and the resultant visual field loss. The MIMS device is a surgical system comprised of two basic elements: the disposable surgical tool and an activation component. The surgical tool is composed of a stainless steel cutting blade with a penetrating tip covered by a conjunctival protector. The surgical tool is then connected to an activation component controlled by a foot switch to produce the rotating movement. The channel is created starting at the episclera behind the conjunctival insertion and ending in the Descemet's membrane anterior to the Schwalbe's line with an orientation parallel to the iris plane. Once the channel is formed, a diffuse bleb rises. The minimally invasive microsclerostomy MIMS technique and device is based on the merging of two well-established glaucoma procedures, trabeculectomy with a minimally invasive approach, needling. In vivo studies to assess the safety profile of MIMS were conducted in 10 pigs where the fellow eye remained untouched and served as a control and had a 90-day follow-up. Subsequently, the performance was analyzed in 8 pigs with a 30-day follow-up. All operated eyes remained white and quiet throughout the study, with no detectable inflammatory reaction, both intraoperative and at follow-up visits. A drainer channel with a targeted diameter of 50 to 100 microns was created in all eyes, as well as a filtering bleb. The IOP was immediately reduced to 5 to 8.5 millimeters of mercury. It remained below the fellow unoperated normal eye for 4 weeks, typical in animal models of filtering operations. With encouraging results from animal studies, it was time to move on to human eyes. Patient preparation begins with subconjunctival mitomycin C injection. Approximately 60 minutes after the injection of MMC, the MIMS surgical tool is introduced via a small conjunctival opening 10 to 15 millimeters from corneal limbus. Once proper penetration is confirmed, the foot switch is pressed and the channel is created by the rotational movement. The device is then removed. As soon as the sclerostomy is made, a nice diffuse conjunctival bleb slowly rises. Immediately post-operative, showing a sclerostomy lumen. Slit lamp examination on the first post-operative day showing a diffuse bleb and the ASOCT demonstrating the opening as well as the subconjunctival bleb. At 1 week post-op, the diffuse bleb is well demonstrated with the slit view, and the corresponding images captured on ASOCT show the presence of the patent sclerostomy along with the bleb. At 6 months, a neat and functional diffuse bleb is well visible, and the ASOCT highlights the presence of a patent sclerostomy. The patients have been divided into 6 groups according to the different device machine parameters used, that is, number of pulses, pulse duration, RPM, and tool diameter. Preliminary analysis of the observations led to consider one design configuration for the future use, referred to as Group 3, with the parameters being 1 0.5 second pulse at 8,000 RPM and 300 micron tool diameter. This configuration demonstrates promising safety and efficacy characteristics. Regarding the adverse outcomes, 3 cases of conjunctival buttonhole, 2 cases of conjunctival tear with Tenon's capsule entangled with the handpiece, and 2 spontaneous outward propulsion of the handpiece with 1 intraocular hyphema were observed. None of these events were seen in Group 3. Trabeculectomy, which still remains the gold standard, carries its own limitations, especially in terms of complication rates. MIMS does not require an iridectomy, and additional complications associated with this conjunct procedure are not expected to occur. Importantly, even if it does fail, the surgical field is still intact for a trabeculectomy. MIMS is minimally invasive with no stitches, no implant, not even an eye patch. Has an extremely low risk of complications such as cataract, hypotony or astigmatism. Can easily be combined with cataract surgery. Spares patients from relying on costly, difficult to comply with drug therapy. MIMS is an efficient surgery which suits a vast majority of glaucoma patients. This is just the beginning. A lot needs to be done to ensure the safety and benefits of the procedure in a larger cohort, and has the potential to become the standard procedure for treating glaucoma and combined glaucoma cataract. Glaucoma surgeons across the globe aspire for a 10-minute procedure which will reduce the IOP by 10 millimeters of mercury and last for 10 years. Will it be a dream come true? Time will have to tell.